Dr. Bhalerao is going to talk about mental health issues and particularly about management and stigma, which is something that I think is very, very critical when we're talking about today's discussion, certainly. Dr. Bhalerao is a psychiatrist, but really I call him a neuropsychiatrist because he's frequently seen up on our neuro ward. Dealing with patients who have had brain injuries and other things that have gone on with the brain. He's a professor at the University of Toronto, in the Faculty of Medicine and Department of Psychiatry, and he's been very interested in getting this message across to the public. And he has an interest, I think he likes going to movies quite a bit. And so he, a few years ago, we talked about a documentary, and he's taking that bull by the horns. He's going to show you a little bit about that. And this documentary highlights some of the difficulties that we've been hearing some of the scientific basis about and some of the medical things, and bring it to a human level. And his research interest lies in examining different options for psychiatric treatment and mental health as it relates to the brain. So we're lucky to have Sri here. Thanks,
first things first, there's a problem, and no matter how you cut it, sure, we're seeing everything from TBI lens, but if you look at every single speaker, if you're not convinced there's a problem, then you should maybe come to the conference again. So that's my message. There's a problem, but the press, the media, the public don't want to get it. Sure, we've got famous people, we've got head injuries, we've got blah, 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 but it's physical, it'll go away, but hey, if they did what I did for a living, again, biased opinion, there's a huge problem. This clinic that we run, day after day, that's all we see is psychiatric sequelae, all the depressions, all the, the self-harms, the addictions, everything that was mentioned today is kind of hidden in this little vat somewhere, and no one's talking about it. So my idea is to bring it out of the vat, whatever term you want to use, and to get people to talk about it. So there's a whole bunch of ways to do that. But the first part of the talk is I have to explain to you what I do for a living in about 15 minutes. And that's treatment. So the easiest thing to do for treatment is to try to pretend we're a patient, all of us, and try to pretend we're an athlete today, showing up in our office. And so hopefully, I'll gently walk you through it, and hopefully you can leave with an idea of what I do for a living in about 12 or 13 minutes, and then we'll go from there on to why I can't get people to see us regularly, which is the stigma and discrimination piece. That's me. Oh, by the way, as an apology, if you need any references, just it's Bhalerao S at smh.ca. Sorry, I didn't have any references, but this isn't just made up. These are all the people that I have to thank, and another person that I have to thank, one of the few residents that actually got on board on this whole thing is Dr. Todd Ryan, so he's around as well, or Ryan Todd, I was getting mixed up, but he's one of the few residents in psychiatry that have actually joined this bandwagon trying to help patients with psychiatric problems secondary to TBI. So thanks, Mike, thanks, Donna, and the talk's going to be non-pharmacological talk, a little bit of pharmacological, and a review of the stigma and discrimination. So we'll just start with the non-pharmacological elements. So patient walks in, you turn off the lights, okay? Whatever. There you go. Photophobia, everyone talks about it, you have to turn the lights on. They hate it. But don't forget, the the preoptic region and the sensory regions are very sensitive to trauma. Hyperacusis, you have to turn the fans down, you have to turn everything with, at least make it as calm as you can. The worst thing is family members talking that make it even more intense for the patient. They have to take a break. Patience, you better slow down. And it's not rapid fire, and you have to wait for the answers, you have to be patient, and that's all shrinks do, are patiently waiting and actively listening. We do a little more than that, but inviting collateral, you have to, the family is a huge source. And sources are required because, again, cognitive problems, emotional problems, things will slow down and they don't remember everything. Athlete issues, this is, I put it in there because when some of these athletes walk in, I am just tempted to say, hey, how you doing? Trying to hang out with them, you know, be cool with them. Oh, how many goals did you get? That kind of transference that we all idealize and worship these guys. Well, at least I do. And but you got to hold back. You're not here for an NHL console. Own reaction. Don't forget, athletes magnify failures. So they are seeing this as a huge chunk to their ego. And that's a problem, and you have to be obviously sensitive to it. They're idealized and they're protected. Probably, and I'm making the number up, from about 12 to about 20. Have they ever made a decision? No. Have they have they been told what to do? Have they been told how to dress? Have they been told, you know, about everything beyond? I'm not saying that they don't make decisions, but I'm saying that they're in a protected environment, and you have to respect that. So you have to treat them differently. So the setting is set, and now we start talking within the office. So the psychoeducation everyone's talked about, you have to provide the education. So I always love the snow globe idea. You have the brain, you shake it. Unfortunately, all the snow doesn't settle the same way that it did before. But a simplistic version, if you look at what Jane was saying and some of the studies that they've shown, it's a disruption in the interconnectedness. So that's a simple way to explain it. And that interconnectedness doesn't settle the same way it did prior to the TBI. Brain testing. So I'd like you, so they're sitting there, we're going to do some brain testing. So what I'd like everyone to do, first of all, I tell them I'm going to test the front of their brain. So can everyone do this? 1, 2, 3. Okay, switch hands. 1, 2, 3. So the front of the brain has a whole bunch of functions, but one of them, if there's neuropsychologists in here, I apologize, I've simplified your life and mine, but so that's one of the ways to test the front of the brain. The side of the brain is I will ask them to put, and you guys pretend there's a clock in you, and I want you to put the hands 10 after 11 on the clock with your hands. Okay. So you need that for, it's a visuospatial task. Athletes need that. You know, you hear about Gretzky's and Crosby's that have this visuospatial sense in athletes. You need that part, plus the integration of the front part, to actually know where you're at on the field or on the ice. The back of the brain is simple to test. Is, does anybody know who I am? And so it's an occipital test, and it's a quick test for the back of the brain. Jane talked about the deep structures of the brain. So now what I want you to do is to pretend you have the letters A, B, C, D in front of you, and I want you to pretend you have the letters 1, 2, 3, 4 in front of you. I want you to connect the letters in sequence with the numbers and the letters. So A1, what's next? And? Okay. So that's a quick way, again, just to demonstrate how we can, and there's a whole bunch of tests, but again, it lets them know that if they're dysfunctional or to a point you can play games with your buddies too, but to test the brain. Another quick thing to teach patients is this. We know that the front of the brain, so take your hand, this is the spinal cord, this is your emotional thumb, or your limbic system. Put this hand over top, okay, you got this thing? So generally, the ridges on the brain are the front and the sides. When the front of the brain bangs into it, this thing gets loose. And this is called flipping your lid. And this is the emotional stuff that comes out following a head injury, is all of that emotional stuff. So again, just providing some quick education to patients is very valuable. So sleep. The bottom line is we have 3 centers for sleep. They're very sensitive to trauma. If you improve your sleep, you decrease the stress hormones and you consolidate memory. And that's a key piece to improving treatment, and everyone's talking about it. Exercise. We know that there's a whole reduction in stress hormones. We also know that it causes people to feel in control, and that is important, very much. But graduated, return to play, and return to learn, and Donna talked about the Ontario Neuro Foundation guidelines. Use those as your basis for how quickly you will return. Stop sign. Every single person with a TBI compares. I was like this before, I was like this now. I'm like this now. It's simple. Put the stop sign up because we know cognitively, if you continue to compare, you're going to feed into your depression, you're going to feed into your anxiety. But that's an arrogant thing for me to say because I don't have the head injury. But you have to get them in that habit of catching themselves before they go into that deeper anxious despair, whatever, or that's not even a word, but I'll make it up. But you have to catch them, and that again gives them a little bit of control of the emotion that might just overwhelm them, and it happens daily. So now we keep going. Mindfulness. This is about a 12-week course, but here's the quick version. You teach them to control their breathing. You teach them to monitor their posture. You teach them to accept that emotions are transient and unchangeable. You teach them to say that cognitions are transient but changeable. So that's where the cognitive behavioral piece comes in. You teach them to accept the emotion and the cognition. And then the fun part is the mindfulness piece is you focus in on the here and now. And literally, you get them to sit at breakfast, pour the cereal, look at the cereal, smell the cereal, pour the milk, eat the cereal, appreciate the milk, and become mindful of the moment. And again, it's a control issue. It gives them a sense of, you know what, there's a ton of stuff going on in my brain, but for the moment, I can feel in control and mindful of what's happening. But that's about a 12-week course, so I thought I'd summarize that. CPT, tons of literature, and we're actually going to start it in the clinic group, cognitive behavioral therapy. It's mindfulness-based cognitive. But we do know that if you give them that added bonus of control of the cognitions, which tend to be negative, you can increase it. And there's also evidence in non-TBI patients for the benefits of CBT, as well as for, you'll see, pharmacological treatments. Social skills training. This is very useful for family members, and it's very useful for patients. They have no clue on the impact of how they're behaving in a situation. The quick version of this is the 3 signs. Have the family members teach them 3 signs. I'm leaving, you're leaving, and stop. Because they will do things that are inappropriate. They may do things unbeknownst to them. And so the family has to get involved and teach them that type. And you can do it in the office as well. A lot of patients, it's interesting, they overestimate how slow they are. In fact, they're not as slow as they think. And you have to reassure them that, you know what, you're kind of overestimating. A term that we use is catastrophizing, but that can apply to a bunch of things. The senses. Now this is, I hate to use the term, not fully used, it's not science per se, but it's brain exercises that I believe are useful. Smelling, tasting, listening, and using all your senses, because it's a regression to how kids learn and how they train their brains. They utilize a variety of senses. So we move away from just, I can't think. Oh, look, I can smell things, I can taste things. So you're stimulating the brain with a variety of other mechanisms. And again, this isn't hard science, but I actually find it's helpful. Memory strengthening, short-term memory, long-term memory, and prospective memory. Lists are great for short-term memory. Prospective memory, I get them to plan things a week ahead. They draw, I'm going to go to a movie next Thursday. Okay, Saturday I'm going to put my clothes up. I don't do that. But, on Wednesday I'm going to invite someone on Thursday. So again, giving that sense of control. The other thing is long-term memory, just have them talk about something in the past. And it gives them a sense of confidence to a point. Pet therapy. We did a little paper on that. It works. You're responsible for that pet, but you also get exercise. And you also get a sense of, there's a sense that you're almost like you're helping the pet as well. And that's a very useful thing to have. Online, as Jane had said, hopefully it works, but there's a whole bunch of factors that are required for it to work properly. Maintain neuropsychological follow-up. Now, I didn't mention that very often, but what will happen is you'll have a baseline neuropsych testing that takes about 4.5 hours to do, but certain situations you have to utilize that data to follow them in the future. Be honest. You do not want to tell this little guy or little person that you got to stop playing sports, but there's a point where you have to be honest, and they're going to ask me, they're going to ask the family doctor, the neurosurgeon, and everybody. Prevention, but here's the shtick. You may have to stop. But you're also you're stuck with a person that's values sports. His may change as his life goes on, but you need to be honest, and safety is huge. Farm. Any questions about the non-farm? Anything? Okay. So naturally we come to the pharmacological issues because that comes up quite often. And the bottom line is you have a sensitive brain. The brain has been shaken. Drugs don't work as well. And you have to start low and go slow. When you look at standard dosing of psychopharm for non-TBI patients, don't use those standards. And the rule of thumb is if someone in the clinic it's usually 1/4 to 1/2 of the dose. So it's like treating a geriatric brain. Antidepressants, they work, and they work. But they can exacerbate post-concussive symptoms, that's why you go slow. As Jane was saying, you're playing with a whole bunch of neurotransmitters. You simplify, just as she has shown. When you simplify, you say, here, there's a whole bunch of sites, they release these neurotransmitters, and they go to a bunch of tracks within the brain. What we're trying to do is to return back to the balance. It's not as simple as, I'm just going to ramp up the serotonin. What you're trying to do is to develop a balance, which in turn will feed into this larger axis, like the hypopituitary axis. If you can quell that entire system, the brain does heal better. And that's the objective. So it's not as simple as just ramping up some neurotransmitters. Stimulants, we talked about fatigue, we talked about the dopaminergic system is used for attention, it's used for pleasure, but generally stimulants such as methylphenidate, Ritalin, your standard, what the kids, all these kids that are using them for ADHD, has been effective and is effective for traumatic brain injury patients. Cognitive enhancers, grandma and grandpa who unfortunately may have dementia and things of that sort, that data is coming. And people are using it. It's a very small niche right now. But again, this is to give you options. And that's the whole objective of this talk beyond trying to push my agenda is to give you as many options as you can. When you go back to the clinic or go back to your parents or your physician, at least you can ask them about the options. Hypnotics, the big thing we talked about sleep. The bottom line is to move away from lorazepam, from clonazepam, like to move towards things like, this is a little less, it doesn't impact memory as much. So I tend to use these type of hypnotics versus benzodiazepines. Antipsychotics, you're going to hear a ton of people on them, and they should be off them. But don't forget, the main reason that people use these is because patients have decreased frustration tolerance, they snap, and can be aggressive. But, actually it's mixed data, but if you give antipsychotics for the behavior, you can slow down cognitive development. But there's some data that says one of them, Haldol, can actually improve cognition. But the objective is to get them off it, but they're also sensitive to the side effects of some of these antipsychotics as well. And they can become overdosed. Mood stabilizers, you'll hear a lot about them. We tend to move away from them, but they are still being used. And really what they're doing is you'll hear they're anti-epileptic medications, generally. And they fool around with these electrolytes. Beta blockers, Donna talked about it. They just slow things down. There's a stronger evidence for its use in agitation and aggression within a trauma unit, not necessarily in the community. Dopamine agonists, just what we talked about, and those are the things that they use for things like Parkinson's and things, which has a similar kind of mechanism to the stimulants. Okay, and these are the others. Hyperbaric oxygen, I don't have one in my office, and I don't know anyone that does. But there's a little bit of data for post-concussive symptoms. People have used it. Electroconvulsive therapy, you can't say no to it because I'm a psychiatrist. It's one of the most efficacious treatments, but not in TBI. But people, it's not a contraindication to not using it. So it's still usable in the modern day St. Mike's Hospital. We still use it if needed. And those are for the extreme depressions. Biofeedback. I love this stuff because it's non-invasive, but it's hard to get. But what it does is it actually teaches patients, so through games, and you can get it at the Toronto Western, there is a lady that started it. But through games, you actually see your brain waves while you're doing a game. And then you do the game and you realize you can change that brainwave. And it empowers patients with TBI to allow them to control their emotions during certain situations. And I actually think it's a very good thing because we have so many adolescents and young people that love games that using this type of biofeedback I think will be very helpful for them. And I've seen a couple of successful treatments with it. Magnetic stimulation, it's coming. And that's Australian data they're talking about using it, and it's good to have on the radar. I don't fully buy into the fact that I buy into the fact that it can help for post-concussive symptoms, but I don't fully buy into the other uses for it. Complementary medications, everyone's using it, and this is my opinion, I don't buy into it, but the people are still using it. And I think that is it. Questions for this piece? Oh, good. Oh, go ahead.
What kind of future directions do you think we should be going in? What sort of future directions do you think we should be going in? I know you mentioned in the last few magnetic stimulation, biofeedback, and a few others, but where do you think what sort of approach should we be trying to develop to get a better treatment?
You'll see my bias. Probably about 70% of patients don't get psychiatric care post-TBI. So my first direction is, let's get them to the trough before we can get them there. And I think that's why a part of what I'm saying is, so once you get them there, I think that the cutting edge piece is multimodal, and multimodal in terms of assessment, but maybe to the point where we know which type of medication is more suited for someone, which type actually has the brain changes. In fact, some of the cognitive behavior, like the mindfulness data, actually says that if you do this with patients, there's an increase in gray matter. So that's get them there, multimodal, and then use technology plus the mixed kind of pharmacological treatment so we can be a little more specific in the treatments. Another version is choosing particular symptoms that are easy to treat and then attacking the psychiatric piece as well. But I think that the first part is getting them there.
Sure. I just have two questions. One, if you could comment on the usefulness. You mentioned neuropsychological testing. The availability of that is very limited, particularly fundage. 4 hours. Professional athletes that I deal with, we deal with that. However, the mass of athletes that I deal with are simple. So if you could comment on baseline testing and the use of, for example, impact, which is widely used, or axing, or those, and then the usefulness of using them in follow-up, so the sensitivity and specificity. And then the other question, if you could comment on, you mentioned medications and such, testosterone and concussions.
Yeah. So neuropsych testing and all of this, I am a big proponent of it, as long as no one's making money off it, and the fact that we're using it for awareness. I agree, like I leave it in their hands to determine, what's the cognitive rehab piece, what is the specifics, that how to strengthen it. But to have the awareness piece is huge, and that's why I would continue it. The use of, testosterone and things of that makes sense. We don't do enough of that. We don't do enough of the testing, and even TS, like thyroid, and we don't do enough of that. I usually inherit them from some of the neurosurgeons that have done it already, but I have had some effect with the fatigue with the testosterone, and a little bit of effect using it for depression. And there's a little bit of evidence to say you can use it, but again, getting the baseline that's what you use as your marker to follow it up. But I don't use it enough as well. There's even some data about estrogen as well.
Could you just comment on the usage of impact or some of these other tests and maybe in the clinic?
Yeah. So I don't use it in the clinic, and we leave it to the field, but sometimes we will have occasional reports that happen, so I can't comment on exactly like using it in the clinic. Okay, we will continue on. Where's Max? Oh, okay, no problem. So we'll take this part then. I guess I can go through. Okay, so here's part 2. So first things first, people don't like me. So I work in the hospital, and your typical comment is, so I work as a medical psychiatrist in the hospital. As soon as I go to any patient, because we get consulted from neurosurgeons, we get consulted from other services, the first thing the patient says to me, generally, what are you doing here? And the next thing they'll say is, so they think I'm nuts. And then the next thing that'll happen is the family will look around and go, what's this guy doing here? So this is what I run across every day. Other comments, oh, you seem too normal to be a psychiatrist. Like, what the? And so every day I'm confronted with this. And I don't mind. Hopefully I have a sense of humor and I have reasonably good ego strength to take a few hits. Maybe not. Maybe that's why this is a projection. I'm reacting against the community really hard, and well, we'll keep it going forever. But that's the typical thing that I run into every day. Now, they looked at how many people do not seek psychiatric help. Close to 50 to 70% of people do not seek psychiatric help because of stigma. So stigma is, you know what, that guy's weird. But the next part is discrimination. That guy's weird, and we're not going to look at him. We're going to ignore him. We're not going to address him. That's my simplistic version of stigmatization. But you have this group of people that don't seek psychiatric help. Now, let's throw in the fact that you're on TV, people worship you, people look to you for advice that you may have no clue about, but they still look to you for advice. And now throw in you have a traumatic brain injury with psychiatric problems. Do you think anyone is going to show up at my office with those kind of odds against him or her? Pretty low. So, a bunch of us decided to have about, what, I think 70 hours of interviews or something like that within the hockey field. And these could be from players, reporters, to kids, to coaches. And we wanted to see what's the scoop and what's the deal with all this lack of care. So I'm going to present a little bit. It's a little. But before I do that, this is where so I just jumped, sorry. So we'll come back to the players and everything. So they did a commission. And this is what I just talked about. So there's stigma, discrimination. But they did a commission on how do you fight stigma? How do you fight discrimination? So they came up with these recommendations that said that you have to accept that education may change stigma for discrimination. Okay? You're supposed to use the media as your allies. I'm not going to attack the NHL. I'm not going to attack whoever that's in charge of sport. I have to join them if I plan to change them. You have to target a specific audience. So the audience that we are specifically attacking and want to get at are athletes, and at least with our documentary, we want to attack or be a part of, sorry, what a slip, the hockey world. So the Mental Health Commission as well did another one more recently, and that they said to fight stigma or discrimination, you have to protest, you have to complain, you have to educate, and you have to expose. And exposure is showing athletes, showing people in the field, and letting the public know what's going on. So, now back to the original thing that I was talking about. So we interviewed all these people, and it was fun, but long. We came up with a bunch of preliminary findings. And these won't be of any surprise to you. And this is purely hockey related. The game is masculine. I don't think I have to tell you that, but fortunately it's sort of a mixture now. At least women are involved as well, but there may be a masculine component within the women's game as well. So we know what comes with masculinity, we know what comes with showing weakness, and we know what comes with just demonstrating your strength. Violence is accepted, even though it's in the rules. you still can hit people, you still are allowed to be violent per se, and the natural tendency is to cheat on the rules. You're going to push it to the edge. And that is a problem. A lot of things that came up was financial pressures. There's this whole thing within the NHL world or in hockey that the fourth liner is expendable. Because, you know, all they have to do is show up, do the grunt work, they still make their money. But to stay in the game, you have to stay in to get a wage. And these guys will fight. These guys will remain in the game, irrespective of what kind of damage they may take on them. And aside to that, just because I'm allowed to do this, I guess, if you listen to Sidney Crosby talking to Mansbridge a couple of weeks ago, he's protected. He's got a huge contract, was allowed to stay off the ice, was allowed to recover, but that probably wouldn't have happened to a fourth liner. And so this is one of the things that I was hoping during that interview, he would have been an advocate for the fourth liner. And he did mention that he knows people that don't return from concussions. I apologize for the aside, but I had to say it. There's a ton of lack of psychiatric information. Some of these players didn't know the difference between, and I don't blame them, between a psychologist, a psychiatrist, and some guy that was just telling them, you know, taking them out for a beer. And so there is a lack of education still in the modern game. And that affects, obviously, whether they're going to get care or not. Stigma still pervades the game. There are people that would not take ownership of whether they had seen a psychiatrist. They just refuse to say, they would not on camera say that they are seeing a psychiatrist. And a common line was, I don't want to be the representative for head injuries in psychiatry. And they're out of the game, but they don't want to be the spokesperson for psychiatric issues. So again, the stigma is still there. So, does anyone have any questions about what we did when we interviewed these people or anything? Anybody? So, with all this information that we had, we decided it was time to do a documentary, which may be ready in about a year. But we do have a trailer. And this trailer, oh, sorry, go ahead.
I don't know if it's a very relevant question, but when you talk about a masculine sport like hockey, baseball, football, whatever it may be, I think it was kind of broken down a barrier with Viagra. A lot of the sports athletes are now promoting Viagra. That's not something a guy usually would talk about. Has that ever been looked at to say, how can we kind of approach it the way they did with Viagra opposed to mental health?
Nothing that I'm aware of that's nothing that's been taken forward that way. But yes, breaking that, I'm just smiling. The piece of that I would use, if you're depressed and it's not working, maybe you should do Viagra. But that's what I would do. But that's the kind of thing we do need. Like I was telling someone, we have a buzz here in the community for a minute and a half of the year, but there's no one carrying it forward into the community. Like we may read about it in the Globe or something tomorrow, and then it fizzles out. But we almost need like a marketing person to push this agenda every month so that so that people get it. And sure, Cialis, Viagra, it's might as well. Yep.
Just a quick comment. I don't know if you are aware of this, but the Lakers, when they won the NBA championship, Ron Artest, before he changed his name, he said, "I want to thank my psychiatrist to do."
Yes, yeah, yeah. And see, it was just a blip, right?
Yeah, it was just a blip.
And we need a few more tsunamis versus blips.
Yeah, and then he
1 minute left. Okay, so here we go. So this is, welcome to TIFF, thanks for coming. And I hope that you vote for the movie of the year. This is it. And again, thank you again, and I hope that you can push my agenda somewhere else. And if you have $200,000 to finish our documentary, please send it.
I have to admit, I am, for lack of a better word, obsessed with hockey. You know, Dad sat me down. Let's be realistic. You're not going to be the first brown guy to make the NHL, like I kept telling him. But at some point, reality bangs you in the head, if you know what I mean. Some shrink said to you, you could become depressed or suicidal because you hit your head on the ice. Oh yeah, go back and play, don't worry, it's only a head injury. Oh, don't worry, just sleep it off. They got this belief that this is how you get rid of aggression, this is how you relieve tension.
We need a guy to step up. We need a guy like Crosby, Lindros, whoever's been in the media for concussions, guys that look in the camera and say, I've been there, I've done that, I get it, and I don't want you to get it. This is not just a bonk on the head anymore.